how we can better integrate palliative care into kidney care. Thank you.
Thanks, everyone. Can you hear me okay? Everybody can hear in the back row? Yeah, okay. Thank you. Jay, thank you very much for that very kind introduction. Thanks for having us. I am hoping that what we talk about is figure out a path together I'm going to use the same metaphor, which is to try to prevent those big fires from starting, knowing that they are there, but figure out together how to prevent crises from happening and take care of people with serious illness. We have no disclosures. What we're going to talk about is really think a little bit about how palliative care fits in with advanced kidney disease, share a little bit about the impact of high quality palliative care and what it does in a cancer setting, and then maybe explore together what a model for nephrology palliative care integration may look like. I will start out with sharing that we are talking about this because of a crisis that we are in the middle of. And that crisis has to do with a lack of hospital beds. I don't know if people have walked through the lobby of Feinberg of Northwestern, and you see that the emergency department has spread out into the lobby and people are waiting there for hours and hours. And that has to do with lots and lots of things. But some of it has to do with the fact that there are really sick people that are in the hospital, stuck in the hospital, some of whom are there at the end of life and dependent on the hospital at the end of life. And that affects quality of care for many, many people. Now, we were asked as a palliative care team to help with that problem, along with many other people. And you might say, why are you helping with that? Or what is your role in helping with that? And part of what brings people to the hospital, keeps people in the hospital, this is data looking at 30-day unplanned readmissions. And if you look, general medicine has the largest percentage of people that gets readmitted. And of people in general medicine, patients with kidney disease make up a large percentage of that. And in addition to readmissions, what we were looking at is, again, this question of who is dependent on the hospital at the end of life. We did an analysis looking at patients who are at high risk of dying. So the SIRI is the Serious Illness Risk Index, which is a prediction tool we have in Epic. If we look at the people admitted to Northwestern with high SIRI score, so at high risk of dying, there is a huge population of patients admitted to general medicine that are at high risk and have never seen palliative care. And of those patients, a large percentage have advanced kidney disease, and nephrology being one of the top diagnoses, although I would argue that there's probably other patients listed with other diagnoses that also have kidney disease. So the point is, there's all these patients living with advanced illness that that are dependent on the hospital, spending time in the hospital at the end of life. And again, the question is, why are we talking about palliative care? And why is palliative care being asked to be part of this issue? Well, we know that palliative care has a proven track record. There's good data to show that when palliative care is involved in caring for patients with serious illness, those patients experience better symptom management, less depression and anxiety, better overall quality of life for both them and their family members. But if we do this well, they also tend to use less resources at the very end of life. We can talk about how that is. But basically, when we align care with what's most important to patients, they tend to choose care that is less intensive, less dependent on the hospital, spending less time in the hospital at the end of life. But what we really care about is like, that's nice, but what we really care about is making sure that patients are getting the best care, the best outcomes with the best experience at lower costs, and making sure that we as providers are also having the best experience and make that sustainable for us to be able to do. That's really what we care about, and that's what we also think palliative care has an integral role in doing. So this talk is really going to think about, we're asked to integrate with lots of different specialties and see how palliative care can enhance care. But these are the 6 questions we're going to try to tackle today. One is there evidence that patients with advanced kidney disease have unmet supportive care needs? Is there evidence that patients with advanced kidney disease have increased hospital dependence at the end of life? Do we have evidence that integrating palliative care makes a difference? What have we learned so far from our own oncology experience? Because that's where we started this improvement project. Who may benefit the most? And then what if we do go down the path of integrating supportive kidney care? What would that look like? How do we do that? So first, there is no doubt that the symptom burden in advanced kidney disease is high. And patients with either chronic kidney disease stage 5 or end-stage renal disease on renal replacement therapy have similar symptom burdens and a decrease in quality of life similar to patients with advanced cancer. This is a study from the Health and Retirement data set that looked at over 1,800 patients. And in the last year of life, the patients who were living with advanced kidney disease had the same degree of severe pain, moderate or severe pain, shortness of breath, or depression as those with cancer in the last year of life. And those patients tended to be older, poorer, had more comorbid conditions, were less likely to have end-of-life wishes recorded or discussed, were more likely to die in the hospital, and more likely to use intensive care. And we know that as patients have more and more advanced chronic kidney disease, they tend to use the hospital more. They tend to depend on the hospital more and have more unplanned readmissions. And that overall rate of about 17% is what we're seeing at Northwestern as well. And the question is there anything that we can do about that to support patients, but also make sure that we're taking care of them in the way that they want? In thinking about that, we need to help people understand what they're facing and what's ahead. And so this study asked or looked at patients who are on dialysis and asked their nephrologists or their nephrology team dyads regarding how they talked about their prognosis or what's ahead. And the study highlighted, which has been highlighted in other studies, that patients receiving dialysis tended to be more optimistic than their physicians about what to expect in terms of survival, quality of life. And that optimism actually is reflected in the preferences that they had for more aggressive life-sustaining treatment. And even more important than that, most patients actually reported that they didn't have discussions with their physicians, and that physicians were reluctant to discuss prognosis with their patients. And similarly, in another study of 584 Canadian patients with CKD stage 4 or 5, again, very few of them reported a discussion with their physicians about end-of-life wishes. But they reported that they actually wanted to talk about it. They wanted to know what to expect clinically, what to expect in terms of symptom management and support available at the end of life. And they wanted their families involved as well. And if given the choice, many expressed the wish to die at home or in a hospice facility, not to spend the end of their life in the hospital. So there's a disconnect here between what people say that they want, what they're hoping for in terms of these conversations, and what is happening at the end of life. Now, it's important that we pay attention to the caregivers as well. Caregivers are affected by what happens to patients, their loved ones at the end of life. And this study looked at caregivers and their report of the quality of care that patients were receiving. And these were patients with end-stage renal disease. And what they report is that, again, they also notice that patients are receiving more aggressive care towards the end of life, and also tend to report that the more aggressive that care is, the lower the quality or the perception of quality of care. So there's this disconnect here between what people want and how they perceive quality care. So there's something missing. There's things we can do, we ought to be doing better. And then thinking again about the caregivers, and by caregivers now I'm going to talk about the clinicians, the people taking care of those patients. This was a study by Melissa Wachterman, who's done a lot of work in this space, asking nephrologists about their experience discussing end-of-life care wishes, discussing prognosis. And it's not surprising that it's really hard. Nephrologists report that it's hard to talk about this stuff. Number one, because there's uncertainty about what to expect. It's really hard to share or predict timeframe or what to expect exactly. There was this sense that nephrologists in this study equated not offering dialysis with death, and death being equated with a sense of failure. But I think even more important, what makes this really hard is that nephrologists talked about having these long relationships with patients. It's really hard the longer we know patients, the harder it is to share those prognoses and to be accurate about prognoses as well. But there's also this sense of failure when talking about dying or not being able to offer treatment to prolong life or improve quality of life. So as part of this effort that, again, as Jay mentioned, we've been involved in trying to figure out how to integrate palliative care upstream, earlier in the care of patients with serious illness. We've done a lot of work with oncology, and we're beginning to do this work with groups in non-oncology specialties. So we had a very small focus group, a meeting with a few people from this division, and we asked, what do you think is part of contributing to this issue of hospital dependence at the end of life? And there's a few factors. One, dialysis or discussions about dialysis and decisions around dialysis often become the turning point for goals of care discussions. And it might be the trigger for those discussions, or it might be the impetus for doing that, but that's usually the point at which they start to come up. Outpatient care is hard because of limited time, limited access, and limited follow-up. It's hard to follow up on these conversations. There are cultural and institutional norms around recommending less intensive or less aggressive approaches to treatment. And therefore, conservative kidney care may be underrepresented in patient education and preparation. And then finally, our system is obviously lacking, and we end up with a fragmented system where home-based care is limited. Caregivers are really overwhelmed and underprepared for what's coming for their loved ones. And so ultimately, patients don't have a choice, right? If they can't get the support they need outside the home, the default is to come to the hospital. And they're so sick that they end up spending a lot of time in the hospital. So what could potentially be the role of palliative care in addressing this issue and answering this question? This is where we look for the evidence of palliative care that makes a difference in end-of-life resource utilization. There's not a ton of studies. Many of them are retrospective and many are outside of this country. But here's one study that looked at over 100,000 patients who died in Ontario, in Canada, between 2010 and 2015. And they looked at patients who had concurrent palliative care with patients who did not have palliative care across many different illnesses. If you look at the patients with end-stage renal disease, those who had palliative care involved in their treatment were less likely to visit the emergency department at the end of life, were less likely to be admitted to the hospital, had fewer ICU admissions, and were more likely to die at home as opposed to dying in the hospital. So there's something about having that palliative care connection that makes a difference. This study, which I really like, it's a small study. It is Italian, so it may not necessarily be totally applicable to how we practice, but this group decided that they wanted to integrate palliative care more into their nephrology care. And so they decided together to do joint training so that they're using the same language, they're using the same skills. And what they did is they recruited patients who were high risk and either were choosing conservative kidney management, or conservative treatment, or CT, that you see on the right, or were patients who were getting kidney replacement therapy but were high risk. So either had multiple comorbidities, were not sure about being able to continue dialysis, but they were enrolled in this program, and they basically followed them forward. And so the patients had regular palliative care visits from physicians, nurses, social workers, along with the care from their nephrology teams. Many of them were living at home. It turns out that with additional support and supportive care, the majority of the patients in each arm did not require any hospital admissions. But even more so, patients who were getting conservative kidney management, not on dialysis, were much less likely to be hospitalized and much less likely to require the emergency department. What I really like about this is the idea of integrating. It's not just adding a consult. It's integrating practice together. This is another smaller study. This is in the U.S. This is a single center pilot study randomizing patients with CKD stage 5 to usual nephrology care versus palliative care plus usual care. And they basically had monthly integrated coordinated palliative care visits. Really, most of them only got 3 visits, with a focus on rapport building, symptom management, coping, and advanced care planning, which is a lot of what we do in palliative care, and I'll talk about what we do in oncology. And what they found is that patients who had integrated palliative care had improved symptom scores, had more advanced directives completed. They didn't necessarily have a significant change in their quality of life, but they did have better physical function. There are 2 pending randomized control trials. The data is not out yet, and one of them just finished. So this is the Prepare for Kidney Care study, which is in the UK, and they are studying or have studied 2 arms of patients over the age of 65 with stage 5 chronic kidney disease, randomized to either responsive management, meaning mixed palliative care and nephrology care, but not including renal replacement therapy, versus patients who chose to receive dialysis. They're going to be measuring and reporting on outcomes. Hopefully the data will be out in the next year or so. Again, this is a UK context, so not necessarily totally applicable to our practice, but I'm hoping we learn more about what they learn. And then the EXPAND project is a multi-centered PCORI-funded study in the US, which is randomizing patients to an educational intervention around conservative kidney management versus a group that gets the education and integrated palliative care along with their nephrology care. And they're going to be looking at decision regret, quality of care, the experience of care, and this won't end until 2029, so it's going to be a while before we get data on this. But I'm looking forward to seeing this, and I think we can learn from this and hopefully will help inform our practice. So there's not a ton of data around palliative care and nephrology or care of patients with advanced kidney disease. But maybe we can learn something from our oncology experience as well, and maybe that helps us design what we might do together. Here's what we've learned. There's really 6 lessons, and I'll talk about it. The first lesson that we'll go over is that integrating care and consistent visits is better than PRN or as-needed visits or one-off consults. This is data from a seminal study from Jennifer Temmel and colleagues. This is probably one of the biggest studies in palliative care. It came out in 2010. And this study looked at integrating palliative care early on with the diagnosis of incurable lung cancer with standard of care cancer care versus a group that just got standard of care cancer care. And what they found, and this has been replicated many times in other studies, is patients who got integrated palliative care, which meant monthly visits in the oncology center with the oncologists or during infusion, those patients had improved quality of life, less depression, less anxiety, and fewer resource or less resource use at the very end of life. And those patients in this study lived 3 months longer than those who got standard of care chemotherapy. Now, that survival advantage has not been shown in other studies, but in the other studies, patients live just as long. It's not like they're living shorter with palliative care. This has been replicated in GI cancers and other lung cancers. Again, the key point here is that integrated care means palliative care practitioners and oncology teams are practicing together. They're not separate. They have regular visits, and we see the same trend in terms of improved quality of life, less resource use at the end of life. Lesson number 2 is that while what we care about is living well, and that's what we want people to live well as long as they can, part of what living well, part of how we inform living well is by talking about what's most important to people at the very end of life so that we help them prepare. And you see that the kinds of things that people care about at the end of life have to do with big things that we need time to help them cope with and prepare for. So finding peace with God, making peace with their family, making choices that allow them to be at home. All of this needs time. This is not an immediate consult. And so having this in mind and keeping this central in what we do is super important. The palliative care syringe. So when we see this data, one of the questions that always comes up is, well, what are you actually doing that leads to these outcomes? And we've begun to tease some of this out, and we tend to say, like, what's in the palliative care syringe? The syringe is made up of really good symptom management, really intensive focus on what patients understand about their illness, what's most important, and then bringing those two things together, psychosocial and spiritual support, and a focus on coping. Now, this is, we've learned from those cancer studies and what we do with our oncology partners in clinic, that we do all these things, different things at different times in different proportions. So when we first meet a patient, we might spend a lot of time building rapport because relationship building is how we get to the hard stuff. So we do a lot of that. It's not just chit chat. It's actually important for us to get to the hard stuff later. But as you see, symptom management is our gateway. So that's how we build trust, is by helping people feel better physically with their symptoms. And a lot of what we do throughout is actually focus on coping. So what do we mean by coping? Coping has to do with the idea that someone might live well and focus on living well while also acknowledging that they have a terminal illness, that they are going to die. That is a really hard thing for people to do. So at the beginning, they might oscillate. That's what this pendulum is for. They might oscillate between, oh, I'm going to be fine, I'm going to live for a long time, and I'm dying right now and I can't live well, to at some point in integrating those two things together and being able to say, yes, I am living with a terminal illness, I am dying, but I also can focus on living well right now, today, tomorrow. That takes work. That's hard to do. And that's a lot of what we help people focus on. And we think that that's actually what helps people with their quality of life and their depression. So when we've looked back, the visits that tend to focus a lot more on coping are associated with patients who report better quality of life and less depression. And when visits spend more time focusing on treatment decisions and eventually advanced care planning, towards the end of life, those are the patients that in the cancer setting have less chemotherapy in the last month or 2 months of life and fewer hospitalizations at the very end of life. Because we need time to talk about these things and plan. We need a different plan for us to be able to prepare and carry out. One of the other lessons, I can't remember what number this is, but the other lesson that we talked about, and where I think people get stuck, is they say, well, I don't talk about prognosis because I don't know how long someone has, so I don't bring it up. I don't talk about it. And one of the things that we've learned, and I think is really helpful in the oncology setting, but really any setting, is we think about prognosis more in terms of what might this look like. Let's think together about what the path ahead looks like rather than how long you have to live. Because we don't really know that, and we're not really good at predicting until the very end. So what might it look like is a more helpful discussion for us to have so that we can plan what's important and how do we make sure you can do as much of that as possible. And then finally, I sometimes forget about the caregivers, but we can't. They're so important, not only for the practical things that patients have to do to get good care and to be well supported at home, but also because caregiver quality of life is actually directly related to patient quality of life. And when patients have poor quality of life or have poor quality deaths, it actually affects the quality of life of those caregivers moving well beyond the time that patient is alive. So it's really important that we focus on this, that they're prepared, they're able to support this care at home. So the bottom line is, if we're, again, go back to this question of how do we do better with hospital dependence at the end of life, we can try to prevent the development of serious illness in the first place, which is a great goal, and we should do that as much as possible. But if serious illness has emerged, how do we create space for patients to be able to prepare for care outside the hospital? And then how do we make sure we have systems in place to be able to make that effective? So we're gonna transition a little bit to think a little bit more about how we together can think about systems to support patients with advanced kidney disease. You can think of the larger population of patients with kidney disease in 3 buckets, and this is way oversimplified. But there's the patients that we see who have acute kidney failure in the hospital that are different from the patients who have chronic kidney disease, maybe on renal replacement therapy already, versus the patients who have chronic kidney disease and are approaching the decision for renal replacement therapy. All of them have some element of symptom needs and need for help with coping. They might all be a little bit different, but we're going to focus on this middle group as we think about a potential pilot or intervention. And I'm going to hand it off to Joanna.
Thanks so much. All right, let's make sure I know how to. Okay, so I'm going to start just talking about a case that is well known to me and some people on our palliative service. This is an 86-year-old man with gout, prostate cancer, falls, CKD5, who was hospitalized this past summer at the VA for falls and weakness. His GFR was 11 at the time, and he tells his primary team that he's not interested in dialysis because that was one of the things they brought up with him. He was very clear. So our palliative care team is consulted, and I'm going to come back to this case after I give a little bit more information and talk about how we would do this consult and what we focus on. So when we're thinking about a patient from a palliative care standpoint that has CKD5, there are certain factors we want to think about as we're approaching talking with them. So one would be their functional status. When we think about that, we're wanting to know, are they eating independently? Are they bathing independently? Are they dressing, transferring, toileting, walking, or moving around? And these sometimes, what I do a lot of training with learners, medical students, residents, fellows. These are things that sometimes really need to be teased out by the physician, because if someone needs their spouse to come into the bathroom and stay there while they're bathing, they need assistance with bathing. And these are things that are helpful to ask about because they give us a sense of how the patient's functioning in their environment. We're going to talk a little bit about frailty, which is a hallmark geriatric syndrome, multimorbidity. So if a patient has 2 or more serious medical problems, we want to think about age. And then importantly, we want to think about goals of care. And what does that mean? Well, we're talking about what does the patient or their surrogate decision maker, their healthcare power of attorney, what do they value? And for instance, if they have a serious illness, do they value most time at home? Do they value most comfort? Do they value most being pain-free? Or do they value life prolongation at all cost? So certainly we see more frailty as people age. My background is in geriatrics, and we learn a lot in geriatric training about frailty. So frailty is an aging-related syndrome of physiologic decline. You kind of know it when you see it. Sometimes when you see a frail patient, these folks have marked vulnerability to adverse health outcomes, including need for nursing home placement. They're more likely to be hospitalized or rehospitalized. They're likely to fall. They're more likely to die. These frail patients can have a steep decline due to a very small stressor. Our ability to maintain homeostasis is affected. And there's no gold standard for detecting frailty, but we'll talk about a screening tool. Why do we care about frailty so much? Well, it's associated with morbidity and mortality. Patients have accelerated chronic conditions. This is more common in patients with serious illness, including cancer. And it's really considered a hallmark geriatric syndrome, where if someone has frailty, they're at risk for polypharmacy, they're at risk for falling, they're at risk for more cognitive decline, they're at risk for delirium, polypharmacy, all these sorts of fragility factors. All these things are things you're going to notice. And I think that, especially in internal medicine training, we're taking care of such an aging population. We're seeing this more and more. This is, there's a lot of different scales. There's a phenotype of frailty. This could be a whole lecture just about frailty, but I just want to focus on something that I think is most useful clinically. This is a clinical frailty scale that was developed in Canada. And basically, it scales patients between 1 and 9. If you're thinking about patient 1, they're generally a very active, older person. When I went into geriatrics, what I realized was that, not every 80-year-old is like another 80-year-old. Like you can have an 80-year-old that's on the golf course 3 times a week. So that's 1, right? But then, if you're getting to 4, those are the patients that are having more trouble. They might be living alone, but struggling. having more problems. There are patients then 5 that start needing help with what we call the instrumental activities of daily living. They need help managing their medicines. They need help with finances. They need help with transportation. And then as we go into 6, 7, 8, 9, these are patients that have real ADL dependence. And these are patients that when we're dealing with advancing kidney disease, we really want to identify these patients because these are patients that we want to be presenting different options to. And why does multimorbidity matter? Again, this is kind of the geriatric term we use for patients with 2 or more serious medical issues. Again, very common as people age to have more than 2. Not every patient with multimorbidity has frailty. Not every patient with frailty has multimorbidity, but there's a lot of overlap. So these are folks that often have decreased quality of life, increased risk of functional impairment, harder to deliver effective treatments for them. They're more likely to be hospitalized. They're more likely to get rehospitalized. They have a lot of healthcare costs, longer lengths of stay, expensive treatments. I just wanted to put up this slide to just show the incidence of who we're dialyzing in this country. So this is between about 20 years, 2001 to 2021. So the biggest age group that are starting dialysis is 75 and up. The next biggest group is 65 to 74. So these are a lot of older patients that are starting dialysis. One of the things we want to try to prevent, and what Eitan was alluding to in his slides, is we want to prevent just dialysis by default. We want to make sure that patients are well educated, the right patients, the patients that we're teasing out based on age, frailty, multimorbidity, options are being presented to them so that they can make a value-based decision. So over 130,000 patients are initiated on dialysis in this country annually. This was a study done in 2020 where they surveyed about 500 patients at different dialysis centers in the Cleveland area, and it was a racially diverse study. And 21% of these patients expressed regret that they had started on dialysis. And, the patients that expressed this regret more often said, the reason I did dialysis was for my family, or the reason I did it is because my doctor wanted me to. The patients that were least likely to express regret had had a conversation about goals of care, and they were more likely to have a living will. This next study I'm going to talk about is considered a landmark study from 2009, and it looked at elderly patients that were nursing home residents that were initiated on dialysis. They looked at almost 4,000 nursing home residents in the U.S. who started on dialysis. The average age was 73, 74. These were older patients, 64% were white. And what they did is they looked at the MDS score, which is what Medicare has regulations about assessing functional dependence in nursing home residents. This is something that's followed. They looked at that and then looked at the patients that started dialysis. And this is a pretty dramatic study in that they found, so first of all, after 1 year, 58% of patients had died, and only 13% of the patients that were studied maintained their functional status. They either died or they had a worsened functional status. So why do we think that this happened? Well, it could be that when the patients started dialysis, they had more of a functional decline. Many of them were probably hospitalized to start the dialysis. These patients had a high prevalence of disability at baseline, 1 or more coexisting conditions. But one of the things that I just want to make as a key point here is that it may be that the benefits of uremia correction in this patient population could be outweighed by the physical risks of and the psychosocial burden of going to dialysis. So many of these folks had to go off-site from their nursing home to go to dialysis. It takes most of the whole day. They're missing meals, they're missing socialization, and many of them just did not do very well. I'm going to talk about another study, which is a veteran-specific study. This was a target trial emulation study, so a type of observational study, where they looked at about 20,000 veterans. This was done between 2010 and 2018. These patients were 65 and older, so older patient population. Their GFR was less than 12, and these were patients that were not being referred to transplant. So that gives you a sense that this was, potentially a even sicker patient population. And they grouped the patients into those that started dialysis within 30 days, or the other group was a medical management group. Now, interestingly, this was really like a real life observational study in that of the patients that did not initiate dialysis within 30 days, about half of them did go on to start dialysis and half did not. So what they found in this study is that after 3 years, the dialysis group that started dialysis within 30 days lived 9 days longer. So only 9 days in 3 years, and they spent less time at home, about 2 weeks less at home. So this study, if I can use the pointer here, as you can see here with all the patients, 9 days longer of life, but then this sort of bluer bar here shows the time that was spent at home. So you can see that the continuing medical management group spent more time at home. And then if we look at the cohort over 80, we do have patients over 80 starting dialysis, piece of information that we think can be really helpful if it's appropriate to share with patients and their surrogate or healthcare power of attorney is that these are patients that did live longer, a little bit longer, maybe about 2 months, but they spent a lot more time in the hospital. So take-home points. Delaying dialysis for older patients is a viable option. We want to make sure that kidney supportive care is integrated into conservative kidney management. Many of these patients, what I like about this study is that some patients did decide ultimately to start dialysis. They started it later, but patients need to be followed up. They need to be given options, and they need to be given some information about prognosis and what to expect in terms of time in the hospital, time at home, if that's something that's important to them. And we just don't want to assume that in older, frail patients that they're going to improve with dialysis. So I think sometimes when we take care of a patient in the hospital that's older, that has multiple medical problems, that's frail, they might be having symptoms related to uremia, but it could be that they're having those symptoms related to frailty. We don't think that dialysis with this subgroup is necessarily going to improve their function or increase their quality of life. So I wanted to just talk a little bit about this conservative management pathway. So Eitan talked about this some, that some of the most advanced work on this has been done in other countries. So the UK, Australia, Canada. It's estimated that about 20% of patients with stage 5 CKD who were referred to a nephrologist and are informed of their treatment options choose conservative care. So that's a pretty substantial number. In a UK national survey from 2015, there was shown to be widespread access to a CKM pathway in most renal units. I was not able to find any standardized approach in these countries. There are certain centers that have more support staff than others, but it's more widespread than it is in the United States. In the United States, we estimate less than 10% of patients are choosing a conservative management pathway. So I think that we have room to go. And Susan Wong is a nephrologist with a expertise in palliative care who's taken a real interest in this issue. And I know she recently, I think, did a Fulbright scholarship in England to learn more about conservative management. This was a decision aid tool that she put together to try to help nephrologists and dialysis staff have discussions with patients and families about conservative kidney management. And what she found is that it was a useful tool, and patients were interested in it. And she found that it helped promote discussions about conservative kidney management in about a quarter of patients. And what I wanted to show, it's about a 6-page tool, but I wanted to show one part of the tool that I thought was really interesting in the way she contrasts pros and cons of dialysis versus conservative kidney management. And I think it highlights some of the evidence I was talking about in these studies, in that, a pro to dialysis, it can give some people extra time, it can improve symptoms, but people can feel tired and they might spend more time in the hospital. Whereas with conservative management, it does frame for patients that home, you're going to spend more time at home if you choose this pathway, because that's something patients may really value. And I think it's important to spell it out for patients. Okay, so circling back to our patient case. So we've got our 86-year-old man with gout, prostate cancer, falls, CKD5, hospitalized over the summer with falls and weakness, GFR11. We're consulted because he tells the primary team brings up with him that, maybe he needs dialysis because he's having all these symptoms. He's like, I do not want dialysis. We're called in. So what do we do as palliative care specialists? Even hearing this one-liner for this patient, I'm thinking already about multimorbidity, advanced age, frailty, and values. So this is a patient I met with. When we walked in, his daughter was in the room with him. He was very clear he did not want dialysis, even though that had been told to him before by his nephrologist. And I think family had sort of assumed he was just like putting it off. He's like, I do not want dialysis. But the daughter said, I'm really worried because my dad doesn't want dialysis. My mom is his healthcare power of attorney. She wants him to have dialysis. And like Eitan was talking about, we're very concerned about the caregiving system because that really impacts what can happen in this case. So this triggers automatically a need for a family meeting. And the patient was agreeable. He was decisional. He wanted to keep his spouse as his healthcare power of attorney. They were very close, but they were at a little bit of an impasse. So we had a family meeting. We listened to the wife's concern. She had caregiver stress. She was very overwhelmed. She was elderly herself. Patient was falling at home. He wasn't doing well. He wasn't really able to ambulate very well anymore. And I think the thought in her mind was dialysis is going to fix him. The patient did not want dialysis. He was not considering it. But we were also concerned that he may say, okay, I don't want dialysis, but then we were putting off a crisis. So we want to try to avoid a crisis. So because this patient was so symptomatic and so weak, this was a patient where I would bring up hospice care. And they were interested in hospice care. I thought it would, give them a lot more support in the home setting. They did also have through the VA a home health aide to help the wife and some family support. And the nice thing about the VA, we have more of an open access hospice benefit. So this patient was doing a little bit better with some physical therapy. His goal was really to try to ambulate a few steps. So we were able to also order home PT and OT for him. And I recently had a follow-up with him a couple weeks ago, and he's doing well. He seems like he's coping, and I think the wife is coping, and hospice is giving them some extra support. So one of the nice things about being part of the VA system is it's our nationalized healthcare in the United States. We take care of 9 million veterans nationally. There are multiple VA sites that are working on kidney palliative care. So we have a national work group that's led by a double-boarded nephrologist palliative care doctor based in Albuquerque. And what's neat about this group is we're able to really share notes. We don't have to reinvent the wheel, but there's a lot of different things happening at different places depending on their staffing, depending on the size of their VA. So some sites have an established CKM pathway. I've listed them here. Some have an integrated nephrologist palliative care specialist. Some just have a palliative care specialist integrated. Some have an embedded NP in clinic. Some don't have those resources. Some are, at our Jesse Brown VA, we're a smaller VA, and we have some great staff, but we don't have that level of staffing. And one of the things this group has inspired me to do was to try to see what I could do to create some sort of CKM pathway at the Jesse Brown VA. One of the things that's been really wonderful is we have a new dialysis educator named Junie Rose, who's a physician assistant with an ED background who started about a year ago at the VA. And I think Eitan alluded to this, that, or he will allude to the fact that we really want to have champions for palliative care because this is how we can affect change. So Junie Rose came to me. The section head of nephrology is very supportive of palliative care at the VA, and she expressed some interest in learning more. We did some teaching. I also looked at her slide deck, so we tried to add information about conservative kidney management to her dialysis educational materials. And then myself and our palliative care nurse practitioner made ourselves ongoing availability for questions. She can get a hold of us quickly. If she has questions about patients, we can make sure to get patients seen in my clinic if needed. And what we noticed happening in the past year is more referrals from her, but also more referrals from other nephrologists. And we have both nephrologists from Northwestern and UIC at the VA. So this is a snapshot of our data from the past year. Junie Rose was referred 108 patients with CKD5, and she was able to connect with 98 patients. So some died, some just weren't, she wasn't able to reach. And then of these 98 patients, 16 expressed to her an interest in conservative management. So 3 of them are now in hospice. One of them I talked to you about. 2, I've met with both of them and their families, were started on dialysis. And 11 are being followed by our dialysis educator, and some are being followed by me. I have a patient I talked to a couple weeks ago who's very stable, asymptomatic, doesn't want dialysis. I haven't referred him to hospice yet because I don't think he needs hospice yet, but we're following along with these folks and want to follow them longitudinally. What are our future plans? So I'm working on putting together to get IRB approval for a dedicated QI project. We'd like to do a needs assessment and a survey of the nephrologists at the Jesse Brown VA. We'd like to follow patients with a symptom scale to get a sense of their symptom burden. And we'd like to set up a pathway where all patients thinking about conservative management are seen by me. And this is doable at the VA because our numbers are not huge. We'd like to have a monthly IDT meeting with our nephrology section chief, the dialysis educator, myself, our palliative social worker, and our palliative NP. And big picture future goals would be having a dedicated CKM nephrology clinic. Because I think one of the things I've learned about in my work at the VA as well as preparing for this talk is how much these patients need follow-up. And I think I could learn more about how to best manage symptoms with end-stage kidney disease. I think that that's something that some hospice agencies may be good at managing, maybe not be as good as managing. So I think I can certainly learn more myself. I'll pass it back to.
I know we're 4 minutes over. I'm sorry. The key point here is that we talk about having an unmet need, and it goes well beyond just referring patients with that unmet need to see a specialist. Hopefully, what we can do over time is figure out how to embed care delivery together and do training. I need to learn a lot about nephrology, and hopefully in working together, our nephrology colleagues can learn something about palliative care so that we can share the same language and develop skills together. So I'm going to end on this slide, which is sort of what we need moving forward. There might be questions in the audience, and we'll hang around. We understand people might need to leave, but if people want to hang around and ask some questions, please feel free. Joanna, are you okay to stay for a few minutes? And then we really appreciate all of your attention, and hopefully we continue to work together on improving care for patients with serious illness. Thank you.